Thank you very much for the invitation to come and speak here. Been tasked to address subarachnoid hemorrhage assessment and management. So in 15 minutes, obviously, you can't be exhaustive on this topic, and there's many reasons for having subarachnoid hemorrhage and lots of detail we can get into. Primarily what I wanted to cover was for the residents and primarily interns and maybe medical students, when you see a patient that you suspect has subarachnoid hemorrhage, what do we do? So subarachnoid hemorrhage is blood between the compartment between the arachnoid and the pia. Oftentimes it is present in and of itself, but sometimes it keeps some different company, such as intraparenchymal or intracerebral hemorrhages, intraventricular hemorrhage, or sometimes often subdurals. And that company that it keeps is probably the most helpful in understanding what the etiology is of that subarachnoid hemorrhage. This is a very typical pattern, starburst pattern of subarachnoid hemorrhage filling the basal cisterns here. If you memorize this picture, this is not the overt picture of subarachnoid hemorrhage. This is kind of the average picture of what subarachnoid hemorrhage looks like due to an aneurysmal source. So you can also have hemorrhages that have some subarachnoid hemorrhage, but you have to look for it. So it's not obvious and glaring sometimes. This looks like intracerebral hemorrhage. You've seen a ton of these, I'm sure, because of hypertensive elderly patients, amyloid angiopathy, anticoagulation use, et cetera, et cetera. But if you're careful, you can notice that there is indeed some subarachnoid hemorrhage down low and extending anteriorly here, and also in the fissure, ciliary fissure there. And that's a very good clue that this may be an arteriovenous malformation that has ruptured and led to the bleeding. Also, while intraventricular hemorrhage is a relatively rare cause of hemorrhage in the brain, if you look at all comers, sometimes this can be caused because of trauma, because of hypertensive etiology, but also aneurysm has to be considered. And sometimes it can be massive, and particularly when you have casting of the ventricular system, you have to consider an aneurysmal source. In that particular case, it was due to this basilar apex aneurysm. And this was treated with coil embolization with a good result there. The patient did well. Far and away the most common reason, though, for having subarachnoid hemorrhage is trauma. So maybe not have seen something quite this extensive. This is a noxic brain injury on top of a patient with a bad trauma and subarachnoid hemorrhage. But far and away, convexity type of subarachnoid hemorrhage like this, where it's filling the convexity spaces in the subarachnoid space, trauma is the biggest etiology for that. The rest of the talk we'll try to focus primarily on spontaneous etiologies of subarachnoid hemorrhage, of which aneurysm is far and away the biggest cause, followed by AVM, and then there's a handful of fistulas, maybe I see a few a year, maybe one a month potentially, fistulas as an etiology. A very important group as well as the unknown reasons. So we may go through an exhaustive evaluation for patients that we suspect have an aneurysmal or arterial source of the subarachnoid hemorrhage, and despite our best investigations, no source is identified. So the various etiologies of those, I would like to also highlight some rare cases and also some mimics, some things that look like subarachnoid hemorrhage. So vasculitis, an inflammatory condition of the blood vessels, can cause subarachnoid hemorrhage. It tends to be focal, but it can be diffuse if it involves large vessels. Dissection, in the vasculitis category, we can also include infectious etiologies, particularly some of the angioinvasive things like mucor particularly mucor can cause large vessel hemorrhage and provide a pattern of subarachnoid hemorrhage that looks like an arterial source or aneurysmal source. Dissection can also cause hemorrhage. This tends to be quite focal, but it can be a little more diffuse depending on how extensive it is. Spinal AVM that ruptures in the cervical or thoracic levels particularly can rupture and cause enough bleeding that it extends rostrally and causes subarachnoid hemorrhage, and more commonly intraventricular hemorrhage. Coagulation disorders obviously could cause it. Sickle cell disease and pituitary apoplexy, usually that tends to be confined to the paracellular space. And then there's many mimics of subarachnoid hemorrhage. So leptomeningitis, because of the diffuse cerebral edema and inflammation within the leptomeninges, results in hyperdensity, and on CT can give an appearance that looks like subarachnoid hemorrhage. Hypoxic or anoxic encephalopathy, a diffuse cerebral edema, which may be caused by either anoxia or by toxic metabolic conditions, poisonings, and then pseudotumor cerebri very rarely can have that appearance. The diagnosis of this in the conscious patient and unconscious patient. So you've heard the neurologic assessment already and how that goes. So in the conscious patient, the patient will notice that they've had the worst headache of their life, and that is oftentimes what they say. So this is written in all the textbooks, and it's written there for a very good reason, because that is the thing that the patients complain of. And it's a very rare patient that will not seek medical attention because the headache is so severe. It's usually associated with emesis, signs of meningismus, photophobia, and then focal neurologic deficits. Most commonly, third nerve palsy is a method of presentation. In the unconscious patient, it's usually sudden loss of consciousness. Many of the patients don't make it to hospital because they may not have medical care in time. And a very important thing to consider is that patients that present with trauma that have no etiology, for instance, it may be a single vehicle accident, or it may be that they just lost control suddenly. Other underlying reasons, such as aneurysmal rupture, have to be considered. So in the differential diagnosis of a sudden severe headache, one of those is a benign thunderclap headache, or also known as a crash migraine. So patients can have a severe sudden onset of migraine, and that can mimic the worst headache of their life and make you think that they have subarachnoid hemorrhage. The key is that this is clinically indistinguishable from subarachnoid hemorrhage due to an aneurysmal source. And so an LP or CT should be done on their very first presentation, because they've given you a good history that they could have an aneurysmal rupture as their etiology. Also, reversible cerebral vasoconstriction syndrome, RCVS, it's also known as benign cerebral angiopathy, and a type of vasculitis can give a very severe type of a headache as well. And the reason for that is because it can be because of illicit drugs or also prescription drugs, and notoriously the SSRIs are the key ones that can cause that syndrome. MRI on rare occasion can pick up some subarachnoid hemorrhage because the MRI is being done for other reasons, or you weren't quite expecting it. And if you don't look for it, then if you're not considering it in your differential, then you may miss it. So I'm not giving you an overt example of subarachnoid hemorrhage, and it can be as benign as this, or maybe even less, just a wisp of blood on the gradient recall echo or GRE sequences. So diagnosis, usually CT scan is what's used to confirm a diagnosis, but then the second most common way is through a lumbar puncture. Lumbar puncture, here are the criteria: 100,000 red blood cells per milliliter, or xanthochromia. It takes a little time for the xanthochromia to show up, but if the hemorrhage has been there for about 2 hours or longer, usually there'll be some amount of xanthochromia. Xanthochromia is where they spin down the cells, and you can look and see what the color is of the cerebral spinal fluid that's the cells are floating within. If you compare that to a traumatic tap, so that's the medical student intern shish kebabs a patient, you can get a traumatic tap, and the way to differentiate the two is that between tubes 1 and 4, there should be a very obvious decrease in the number of cells, and the supernatant, after it gets spun down, the cerebral spinal fluid should be clear. So both of those things can be helpful. Other things, kind of ancillary things, you should always measure an opening pressure. Most patients with subarachnoid hemorrhage, I've yet to encounter a patient with subarachnoid hemorrhage that didn't have elevated opening pressures, versus a traumatic tap that obviously have normal pressures. The other thing is that if you want to be completely certain about it, is that you can do a lumbar puncture at the higher level. So usually we do it at L4-5, you can go to L3-4 very safely. and check at that level and see what the fluid looks like to differentiate it from a traumatic tap. Obviously, it shouldn't be bloody at the higher level for traumatic tap. And here's what xanthochromic CSF looks like after it gets spun down, has this yellowish color. Sometimes you can use UV vis spectrophotometry to differentiate it if it's subtle. Usually it's not so subtle. Rarely patients will have a sentinel headache, so they have a mild hemorrhage. They don't go to the hospital and they come back with a bigger bleed. And so it's really taking this in the context of a patient who's never had a headache, is an adult, not a young person. Young people can maybe develop migraines, but an adult presenting with a headache, relatively acute in onset, that should be taken seriously. And so CT or an LP can be done very easily, and to rule it out, give the patient peace of mind. And if you recall that each successive hemorrhage from a subarachnoid hemorrhage is worse than the preceding one, it carries a mortality rate of about 20%. So it's important not to miss this. That's where the history is extremely important, and then the physical. So the management, again, these patients can present with severe vital sign perturbations, particularly because of the effect of the sudden increase in the intracranial pressure. And if they already have some amount of coronary artery disease, or if they're presenting as a motor vehicle accident, can be hemodynamically unstable. So going through your ABCs, and as neurosurgeons, we tend to focus on the brain issues or the neurologic issues. We have to consider the whole patient. As Doug Orr just said, it's hard to operate on a dead patient. After we do the ABs and Cs, we can stabilize the blood pressure. Oftentimes these patients have very, very elevated blood pressures, and we want to get that blood pressure down as soon as possible in order to prevent rebleeding. Usually we aim for 140, 160 is probably also a reasonable systolic blood pressure goal. And then the D of the ABCDs is a drain for a hydrocephalus, putting in an EVD. Then the diagnosis of the etiology of the subarachnoid hemorrhage, and then finally the treatment. So which has a higher risk of elevated intracranial pressure? A patient with an intracerebral hemorrhage or a subarachnoid hemorrhage patient? Is there an intern that wants to answer that question? Why is that? Yeah, that's exactly right. So even though the intracerebral hemorrhage often seems the more dramatic, and from a volume standpoint, the volume of blood that there is in the brain may be higher with the intracerebral hemorrhage, the issue is with the CSF circulation problems that can occur because of the subarachnoid hemorrhage. So it doesn't take much to cause that to be disturbed and result in big problems. So the initial management, after you put in that drain, really important not to drain all the CSF out. Okay. It's really important not to drain all the CSF out, because if you do, the patient will re-rupture their aneurysm. So we keep the EVD set at 15 centimeters of water or 20 millimeters of mercury approximately. We'll skip over that. Aneurysmal subarachnoid hemorrhage we'll focus on primarily. There's a Hunt test system, and the importance of that system is really to understand the prognosis from a morbidity mortality standpoint for the patient. And if you take even grade 0, which is unruptured aneurysms, grade 1, and grade 1A, which is no meningeal reaction, the mortality rate from that is still approximately 20%, because vasospasm is still a big issue, and that can result in downstream effects. When you have grade 2, they have some cranial nerve palsies. The headache is more severe, more neural rigidity. And then in 3, 4, and 5 all have some sort of cognitive effects. And then we add 1 point to all of these for patients with severe systemic disease. So this is uncontrolled hypertension that pre-existed the patient's hemorrhage, diabetes, COPD, or vasospasm is already present. There's also what WFNS grading system, which is based on the GCS, and within that, basically, if a patient has a major focal neurologic deficit, cranial nerve palsy, decreased level of consciousness, then they're in this higher grade. If they do not, then they tend to be in the lower grades. There's also a Fisher grading system based on the CT appearance and how much blood is present, and this has its greatest impact on the risk for vasospasm. Here are the admitting orders. We'll skip over that. And the diagnosis of the subarachnoid hemorrhage most commonly is done with a CT angiogram initially, and then a confirmatory angiogram to follow up. You can see middle cerebral artery aneurysm here. And this is the real key. We want to avoid rebleeding. So we want to get that aneurysm secured within 24 hours. If it's not within 1 day, the rebleeding rate's about 4%. Within 2 weeks, it's about 20%, and at 6 months, it's 50% if the aneurysm is not secured. So the treatment before, used to have very little overlap over time. That overlap has increased as endovascular devices have broadened and become more complex. But instead of thinking of it as a surgical management versus endovascular management, it's better to think of it as a reconstructive or deconstructive strategy. So in general, we try to aim for reconstruction as much as we can. We don't want to sacrifice blood vessels if we don't have to. But oftentimes, deconstructive strategies such as bypass or trapping, parent vessel sacrifice after balloon test occlusion has been done may be necessary. And this parent vessel sacrifice can be done either surgically or endovascularly as well. And the reconstructive is either clipping, coiling with various adjuncts, or flow diverters. So the best treatment is determined based on how much intracerebral hemorrhage or intraventricular hemorrhage they have. If they have a big intracerebral hemorrhage and you need to go and remove the clot anyway, then sometimes we just go ahead and clip that patient's aneurysm. The location of the hemorrhage, most anterior circulation aneurysms, are up for debate. How best to treat them based on the specific patient characteristics. But posterior circulation aneurysms, far and away, with the exception of picas, we tend to treat endovascularly. Age and proximal tortuosity also play a role. And the last thing I'll touch on before finishing, sorry for running a little bit over, is that vasospasm is a big deal. So you've now seen the patient, you've stabilized them, they're sitting in the ICU, you've secured their aneurysm, and one of the most disheartening things is to watch a patient progressively decline because of vasospasm. So really the key is to be ahead of the game, not to artificially lower their blood pressure and let them auto-press themselves up to 180 or even 200 depending on their cardiac status. So we tend to get an echocardiogram in elderly patients just to see how hard we can ride them with either pressors or let them push their blood pressure on their own. But watching for vasospasm is the key, and this is where the nursing really comes into play. The nurses are the first line of defense, and if they're doing their accurate neurochecks every hour, then they should be able to pick up a neurologic deficit very quickly, and that should be taken seriously. If you let it go for a couple of hours, and they'll likely have deficits that will be irrecoverable. And here's vasospasm. You can see supraclinoid ICA, the middle cerebral M1 segment, A1 segments with severe vasospasm. Here's that same patient that we showed the CTA on. You can see this small aneurysm. I didn't show any dramatic cases. This is simple, straightforward middle cerebral artery aneurysm clipping as the clip is being applied. And then we can do indocyanine green angiography at the time through the microscope, fluorescence microscope, and confirm that we have it occluded. So the triple H therapy, these two are the most important. Hemodilution, I'm not really sure how important that is, but it sounds better for it to be triple H as opposed to double H, I guess. But hypervolemia is the real key. Make sure that the patient's well resuscitated with intravenous fluid, especially if they're not eating and drinking, and then watch for hypertension. Cerebral salt wasting is also an interesting endocrine disorder that happens to a lot of patients with subarachnoid hemorrhage, and maybe a harbinger of a vasospasm onset. And so that can be very dehydrating for the patient, so daily weights are really important. And then we can, after these things fail, we can do endovascular spasmolysis, where we take a microcatheter and infuse very focally spasmolytic agents such as calcium channel blocker, verapamil, and nicardipine, and we can also use angioplasty. So I'll stop there, and thank you for your attention. I think we have time for questions. Thanks.